biobanks have been very useful the past 30 years, and I see for the next year and next 10 years, biobanks will be even more important, because if we would like to implement the personalized medicine on primary care level, like prevention and prediction of early disease or determine the risk of the disease, genetics has to be part of it. And genetic markers are the most important ones. And now I think that the technique which we call polygenic risk scores is most innovative medical technology which can be applied on population scale. In order to apply it, we have to have a genetic data on population. Now biobanks have this data. In Estonia, we have 20% of people in biobank, and we have also data, genetic data, imputed array data, NMR data, so on. But we need also the rest, because we have to provide health care to everybody. And why we have to do it is that we have too many patients. People are living longer. Old days you get more diseases, but lots of these diseases can be prevented or postponed at least. So people are living with disease too long. Average life expectancy is more than 80 years, but health years is only about 60. So last 20 plus years you are suffering or something. And this we can change, because we are not using genetics in early detection of the disease risks. And there are always something you can do if you know your risk. It's not only you take a pill or you do something, but you can do yourself. And this is, I guess, a fundamental change. We have to move away from, not completely, but we have to move from tertiary and secondary health care to the primary care, primary prevention. And that means personalized prevention, because everyone is a little bit different, but people are more motivated to do something if they know about their own risks. In Estonia, I have been returning data to 5,000 people on primary care level. GPs, family doctors are working, and everybody's happy. Actually, lots of good things coming out of it. So I have to expand it to the rest of the population. At the beginning, you don't have to take the full population, but take age group like 40 to 70, where results are most obvious. And if this is done, then you can move lower, like from 20 to 40. So, but we can't change the healthcare situation if we are not going to use personalized prevention of disease. And this is crucial. Technology is all there, but only thing we have to change, of course, lots of kind of legal, ethical things, this can be all done because they are not coming from the moon. It's people decide what to do. But people's mindset, psychology, this is most difficult to change. In Estonia, I've been doing it for 25 years. Only now, from the next year, first service in public health care will use polygenic risk score in predicting breast cancer risks. Private sector is offering this already last 3 years for certain cancers like melanoma, prostate, breast, and prostate. But now only the public sector is picking up. So it's coming, but it takes time. So biobanks, now if we are thinking about European approach, because Estonia is small, but we are working on European scale also. And now the biobanks are very important because we have more than 100 million samples collected in different biobanks across Europe. BMRI actually has a catalog on all of it. And we know where they're coming from. So of course the consents are different, and health information is different, but this all can be harmonized. But at least we know the samples are there, people know where they're coming from, and at least for the beginning we can use the biobank data and samples to do the genotyping across Europe. Because what is going on now is a project called Genome of Europe. We are sequencing 100,000 people across Europe, 40 different populations. And this is providing the reference database. The rest have to be microarrayed. microarray is very cheap. It's less than 20 euros piece. And if you use a saliva kit, you just got everything done less than 50 euros. And you have to do it done once in your lifetime. So for 50 euros, you don't get too much in healthcare. But spending this money on major part of population will change a lot. And I think this is where you have to go, because we are getting less and less doctors. We are less and less money. And we have to use technology in order to keep people more healthy. Healthy people are more happy, they are working longer, paying taxes, so everybody's getting benefit. There is only one thing which to me looks like difficult. And I proposed in Estonia that we have to do this one. The hospital, large hospital directors wrote immediately to the newspapers that, look, this thing is not really good. Because the hospital director told me, look, if my budget will be reduced 10%, I'm against it. But now in the Estonian healthcare budget, only 1.5% goes to prevention. And this is definitely not enough. It involves a newborn screening for probably 20 conditions, which are very rare. But to shift the budget away from large hospital to prevention, this is, I would say, a major thing to do. But healthcare insurance and the private insurance, they are all for. And we have to make sure that people would like to do it, get involved. And then if people want to do it, government has to make decisions.